All right, in this PowerPoint, I'm going to just do a brief overview of ventricular rhythms. So when we have a ventricular rhythm, the electrical impulse is beginning somewhere in the Purkinje fibers of the ventricles. So we get this kind of retrograde conduction because we're kind of moving from the bottom of the heart up to the top of the heart. So it makes our QRS look a little weird. Our QRS complexes are going to be very wide, so they're going to be over 0.12 seconds or over those 3 small blocks. We'll probably not see P waves. Usually the P waves will be hidden inside of the QRS complex because the atria is depolarizing at nearly the same time, and the ventricular contraction just has a higher electrical impulse with it, so it's going to cover up that P wave. Our ST segments are going to deviate away from baseline, and that is just because the pathway of repolarization. So remember, before I talked about how we're kind of generating this impulse at the bottom of the ventricles. So here's our atria and then our ventricles. So this impulse is going to be traveling kind of backwards. So it's not that we have ST segment depression or elevation, it's just that we have this alternate pathway of ventricular depolarization. So it's going to look a little weird. And depending on whether it's coming from the right side of the heart or the left side of the heart, it's either going to look like ST elevation or ST segment depression. So we are not, and again, that is not due to any kind of infarction or any kind of ischemia. It's from that retrograde depolarization. So when we are labeling these rhythms, even though we have these huge, weird deflections, we are not labeling that as ST segment depression or elevation because it's not true ST segment elevation or depression. So make sure you're not putting that in your name. It's normal for these ventricular complexes to have either elevation or depression. So ventricular rhythms in general, they can be life-threatening. We're going to talk about some of our less severe ventricular rhythms and then our more severe ventricular rhythms that are life-threatening. It can result from just the SA node and then the AV node failing to generate a pulse. So we know that if we lose our SA node, which gives us our sinus rhythms that are 60 to 100 beats per minute, we kind of fall down to that AV node, which gives us our junctional rhythms that are 40 to 60 beats per minute. And then if that AV node also fails, we could see a ventricular escape rhythm, just like our junctional escape rhythm, but now in the ventricles, ventricular escape, where it's only 20 to 40 beats per minute because that is the pacemaker of the ventricles. So sometimes we do see this in the process of death, where they'll go from a sinus rhythm to a junctional rhythm down to a ventricular escape rhythm. And that's just the constant failures of all those pacemakers, kind of like a domino effect. Or it could be due to some kind of ischemia or infarction where we get some of these tachyarrhythmias. So one of the first things we're going to talk about is our least severe, and those are our PVCs, or premature ventricular complexes. So they're kind of the same concept as a PAC or a PJC. So we have an area where the PAC is going to be an area in the atria that's kind of firing prematurely because it's irritated. With a PJC, it's that AV node firing prematurely because it's irritated. And now a PVC will be an area in the ventricles that is firing prematurely because it is irritated. So it's some kind of beat that's coming from somewhere in the ventricles, and each spot in the ventricles will have a different appearance to how that PVC looks, but it happens before that next sinus beat should have occurred. There's a lot of causes of this, and sometimes it can happen in healthy people. We don't even know why. So it's usually not for concern, especially if we only just have one. Our biggest concern with this is that if we have a lot of PVCs, we don't really get complete ventricular filling. So when we get a lot of these PVCs in a row, we could have a decrease in cardiac output because we don't know how much stroke volume we are getting with that PVC beat. So some of our common causes, it can happen with ischemia, hypoxia, could be some electrolyte or acid-base imbalances. We do see this a lot in CHF because in CHF patients, they do have some ventricular muscular damage. So we could get some irritated spots there. It could be simple things like stress or fatigue. Sometimes if we're just tired, we can get some of these PVCs just happening prematurely. Stimulant use is a common cause of this, so anything from caffeine to your cocaine, and then some pathomimetic drugs. So that would be your epinephrine, your dopamine, levophed, norepi, those kinds of drugs that kind of mimic that sympathetic nervous system. Now, PVCs can either be, we need to define them. We need to look if we have more than one PVC in a rhythm. So up in this rhythm, you see we have 2 PVCs here. We need to look and see what they look like. If the 2 PVCs look the same, so when I look at this PVC and this PVC, their shape is generally the same. We call those unifocal PVCs, and unifocal just means they're coming from the same spot in the ventricle. Let me get rid of that there. So they're coming from the same spot in the ventricle, just meaning that I have the same irritated spot in the ventricle. So this is something better we see, so it's better to have only one irritated spot in the ventricle than multiple, and we'll take a look at what that looks like. But we would note this when we're putting this in our rhythm name. We put it at the end with ectopies, where we put like our ST segment changes or ectopies. We would just note that as unifocal PVCs. So this here is a sinus rhythm with unifocal PVCs. Now, when we start getting PVCs that look differently, this is telling me that I have 2 different PVCs that don't look the same. We call those multifocal PVCs because they're coming from different areas of the ventricle. So this is a little bit more concerning because now I have multiple areas in the ventricle that's kind of prematurely firing off, which means my ventricles are a little bit more irritated than if they were just coming from the same place. So we would call this multifocal PVC. So this would be a sinus rhythm, and I don't know the rate, I didn't really look into it. So sinus rhythm with multifocal PVCs. Now we can get something happen where we have 2 PVCs happen together. So we have 2 PVCs right in a row, and that's just that irritated spot firing off, boom, boom. And it creates a pair of PVCs. We call that a couplet. So a couplet of PVCs. Now, typically couplets are unifocal. So if it is unifocal, don't worry about putting unifocal couplet PVCs. But every once in a while, we could get a multifocal couplet PVC, which is where I have 2 different spots rapidly firing in the ventricles. Now, that would obviously be a lot more concerning. I've only seen this one time in my entire career, so it's very, very rare. But if it is multifocal couplet, make sure you're putting multifocal in front of that couplet PVCs because it's out of the ordinary that it would be coming from 2 different spots. This is a little more concerning than just one PVC. I'm definitely going to want to monitor this patient because I could get more and more PVCs in a row, which would lead me to the next thing we're going to talk about, which is run of attack. And the ventricles are very irritated. Make sure we're doing a 12 lead so we can pick up any ischemia or infarct as well. Now we can't get triplets, and that's 3 or more PVCs in a row. Some texts automatically say if you have a triplet, it's considered a run of attack. Some texts call it a triplet PVC. And again, they're typically unifocal. So if it happened to be multifocal, make sure you're highlighting that in the name because it's kind of out of the ordinary. But triplets are when we have 3 PVCs in a row. Anything that's more than 3 consecutive PVCs, so up here we have 3 in a row. If you look down here, we have 4 in a row. We would consider that a run of attack. Some texts consider 3 in a row a run of attack. So I'm not going to get too picky on what you decide is a run of attack, but make sure if you're not calling this a run of attack, you're labeling that as a triplet PVC, triplet of PVCs. Definitely more concerning. I have a lot of ventricular irritability here. So I'm going to start worrying about this patient going into a ventricular rhythm. Now, we also are at risk for something called RNT phenomenon with these runs of attack. So I do want to talk about that quick. We know that the R wave represents the ventricles depolarizing and the T wave represents the ventricles repolarizing. So my R wave, which is the top of this QRS complex, my ventricles are contracting. Okay, they're depolarizing. And then during the T wave, my ventricles are kind of recharging for that next depolarization, that next contraction. So what happens when we get an R on T phenomenon, we're kind of crossing paths of that depolarization and that repolarization, and it's going to crisscross our electrical impulses, kind of causing it to go into a crazy rhythm, right? So we don't want that to happen. It's going to cause a VTAC or VFib or a torsade, which we're going to talk about those rhythms next. But basically what we're looking for when we start worrying about an R and T phenomenon, I have a sinus beat here. We'll just call this a sinus beat because this one looks like I have some artifact there. And then my T wave, but I have a PVC happening like so close to that QRS complex. So the closer that your PVCs get to that QRS complex, we start worrying about an R and T phenomenon, because what's happening here is this ventricle with this PVC is prematurely depolarizing. And I don't want that to happen while the ventricles are trying to repolarize here. So you can see here, we had that R and T phenomenon where this PVC fell right on that T wave, and we saw it kind of come in here because it was getting really close, and it put this patient into a rhythm that's not conducive with life. Now our PVCs can also happen in a pattern. So when we do have it happening in a pattern, we definitely want to note that. So the first thing we're going to talk about is bigeminal PVCs. Bi meaning two. So bigeminal PVCs means I have a PVC happening every second beat. So if we look here, I have a sinus beat, and then this is a PVC. It's just smaller because it's a low conducting PVC, but it's still PVC. So sinus beat, PVC, sinus beat, PVC, sinus beat, PVC. So my worry with this is that PVC conducting a pulse? Now for testing purposes, when you're doing rates, we'll always assume that the PVC is conducting a pulse with this rhythm. So if you had this as say this is a 6-second strip, and again, I don't know how many seconds it actually is, but just hypothetically, if this up here was a 6-second strip, I would count my rhythm 1, 2, 3, 4, 5, 6, 7, 8, 9. I would consider that 90 beats per minute on a test. Now, if this is an actual patient, I actually need to put hands on that radio pulse, and I need to see, is that PVC conducting a pulse? Because if that PVC is not conducting a pulse, now I have a rate of 1, 2, 3, 4, 5, and my patient's at risk for being bradycardic, which means I'm going to have a lower cardiac output. So make sure you're actually putting hands on that pulse to see if that, if they're in a bigeminal rhythm, is that PVC conducting a pulse with it? Did we get enough ventricular filling, because it did happen prematurely? Did we get enough ventricular filling that I actually get a stroke volume with that's pulse producing? So this is bigeminal because every second beat is a PVC. So I would label that as a sinus rhythm because my underlying rhythm is sinus. I have a P wave, a normal narrow QRS, a little T wave here. I obviously didn't get enough into my repolarization before I had this PVC. So my underlying rhythm is sinus. So I have a sinus rhythm at, we'll say 90 beats per minute with bigeminal PVCs. And that tells me that I have every other one of those beats is going to be a ventricular complex. If it happens every third beat, we call that trigeminal. So I have a sinus beat, PVC, sinus beat, PVC. So it's happening every third beat. So this would be a sinus rhythm at, we'll say 1, 2, 3, 4, 5, 6, 7, 8, 9. Sinus rhythm at 90 beats per minute with a PVC or trigeminal PVCs. And then if you have it every fourth, we call it quadgeminal PVCs. And I would never expect you to label quadgeminal PVCs on our test because we typically give you 6-second strips. And as you can see, you really can't pick up a pattern when you only have 2 PVC complexes. So typically we don't label those quadgeminals. Now your treatments of PVCs really is just supportive care. Make sure you're doing a 12 lead so we're looking for any ectopy that could be causing those PVCs. Make sure they're not hypoxic. We definitely want to put a cardiac monitor on this patient during our transport because we want to start looking for those runs of VTAC. But we typically don't treat these with an antiarrhythmic. We can consider an antiarrhythmic, such as amiodarone, if they start having runs of VTAC. So if my patient starts having runs of VTAC, I go ahead with that amiodarone drip to stop that from happening because I don't want that patient to slip into VTAC. So only consider an amiodarone drip when you start having runs, so 3 to 4 or more PVCs in a row. Now we're going to go into our actual ventricular rhythms. So these are rhythms that are coming from the ventricles themselves. So our first one is going to be our idioventricular rhythm, also called a ventricular escape rhythm. And I kind of like this word better because it kind of sticks with the same concepts of junctional escape rhythm. So in a ventricular escape rhythm, my pacemaker site has escaped to my ventricles. And we know that the normal ventricular pacemaker is only 20 to 40 beats per minute. So this up here was a 6-second strip, and it kind of got altered, and it was 40 beats per minute for this ventricular rhythm up here. So originating in the ventricles, 20 to 40 beats per minute, also called ventricular escape. I do have a lot of students call it idioventricular, which is fine. And basically, this is kind of what we talked about in the beginning. My SA and my AV node have failed to fire. So my pacemaker site slips down to those Purkinje fibers somewhere in the ventricles where I'm going to start producing my pulse. Most of the time when I see idioventricular rhythms is in times of death. So our patient is literally actively trying to die, whether it be from heart failure, from any slew of different things, but we see this sometimes in hospice patients. We also see this a lot of times right after we defibrillate a patient, but really we should be going right back into CPR, so we're not really focusing on the monitor anyways. Your signs and symptoms for idioventricular rhythm, your patient's definitely going to be hypotensive, they're definitely going to be bradycardic, probably, very shocky. I've had patients come in for weakness or syncopal episode. We put them on the monitor and they are in this idioventricular rhythm at, 35 beats per minute. And you're kind of wondering, how is this patient even still alive? So definitely something that we need to fix right away. Our treatment for idioventricular rhythm is going to be transcutaneous pacing. Most likely we're going to just go straight to transcutaneous pacing because this patient's most likely going to be very, very unstable. And we know that TCP is what we use for stable bradycardia. We can't, really use atropine on these patients because if we think back to how atropine works, atropine speeds up conduction through in the SA node. So it's basically stopping that acetylcholine that helps slow down our heart rate. So increasing conduction through the SA node when my pacemaker's happening down in the Purkinje fibers isn't really going to have any effect on this patient. So that's why we go straight to TCP. If you do want to use a medication, we're definitely going to go straight to our dopamine drips down here. Now what makes this really ventricular is look at this QRS complex. It's very, very, very wide and bizarre looking. It probably ends right about there. These are really hard to measure out because that end point is very hard to find, that J point. But it's very, very wide and bizarre looking in nature. And again, this is not any kind of ST change right here. This is just that, retrograde conduction. Because when we think about my heart, I'm producing a pulse somewhere down here in the ventricles, so my electrical impulse is kind of traveling backwards. So that's what this is. This is not ST elevation or ST depression. Don't label it as such. I would label this rhythm as ventricular escape rhythm at, looks like I have about 35 beats per minute just looking at this section. So idioventricular escape or ventricular escape or idioventricular rhythm, whichever you want to call it. I like to stick with ventricular escape rhythm at 35 beats per minute. Here's just some examples of some different idioventricular rhythms. These are both 6-second strips, so I can just do my 6-second technique. 1, 2, 3, 4. So this would be a ventricular escape rhythm at 40 beats per minute, or you could call it an idioventricular rhythm at 40 beats per minute. And then sometimes when we get very close to death, it doesn't necessarily happen in a regular pattern. So I just don't want you to assume just because it's regular, it has to be ventricular. It can be irregular as well. But again, we see this pretty much right before patient arrest. This patient is probably arrested because this is only 20 beats per minute. So we don't have anything slower than idioventricular because they would probably just be dead. Once you get below 20 beats per minute, that's not conducive with life. So again, this one down here, idioventricular at 20 beats per minute or ventricular escape at 20 beats per minute. And again, you can just kind of note that very wide, bizarre QRS complex. So you don't even have to measure this to tell how wide the complex is. All right, so we can have an accelerated ventricular rhythm. So just like with our junctional escape rhythms, we can have an accelerated. So that means it's over the normal amount for your pacemaker site. So the Purkinje fibers really only go 20 to 40 beats per minute, but it's not quite tachycardic, so it's under that 100 beats per minute. So accelerated means it's above the intrinsic pacemaker site, but it's not quite tachycardic. So accelerated ventricular rhythm, some people call it an accelerated idioventricular rhythm, are when we have ventricular rhythm that's between that 41 to 100 beats per minute. So it's over the intrinsic rate of the pacemaker, but it's not quite tachycardic. This is a very rare rhythm to see because usually if they're in this rhythm, they're either going to be speeding up to VTach or they're going to be slowing down to ventricular escape. So it's kind of a weird spot to be in. If you see this in your patient, it's probably going to change. But for like this example, we have 6 complexes, so about 60 beats, and you can see my QRS very wide. So that's what makes it ventricular, is that it has a wide QRS. I don't see any P waves because they're probably hidden within the QRS. And then we have ventricular tachycardia. So VTach is probably the most common pulse-producing ventricular rhythm that I see, unfortunately, and it's also very serious. But this is when we have a ventricular rhythm. So, I can't even tell you where the QS complex is here. I'm going to assume that it's, something along that measurement, but very wide, okay? So I can tell this is a wide rhythm. So it's a wide, fast rhythm. So wide QRS complex, my rate is going to be over 100 beats per minute. And this is basically where it's coming from the ventricles, but the ventricles are so irritated, they just kind of start rapid firing. So something is severely irritating those ventricles. This can produce a pulse, and we call that VTach with a pulse. It can also be pulseless, and we call that pulseless VTach. And this week we're kind of focusing on pulseless VTach with our treatments. But make sure you are checking for a pulse on your patient. But basically our ventricles are beating so fast. Our ventricles are very thick and muscular, so they don't like beating really fast, and they also don't really have time to fill. So our patient is going to have this kind of sudden decrease in cardiac output if they do have a pulse, or they're not going to have a pulse at all. So when I see this rhythm, I prepare for my patient to code, because I know that they're going, even if they are stable at the moment, they're going to become very unstable very quickly. So I put a lot of, different examples of VTach here. Basically, the faster the VTach gets, this one is about, I can't remember, this patient was about 220 times a minute. So this rate is about 220. I know the blocks aren't on there. But very, very fast VTach. And you can see it starts getting a little bit more narrow just because there's less time for that to produce. This patient, a little closer to like the 100s than the 200s. And you can see it's a little bit wider because we have more time for that to depolarize. But most common cause of VTach is going to be your myocardial infarction, so heart attacks. We see this commonly in heart attacks. We can see it with severe ischemia, cardiac ischemia, especially some widespread ischemia. Other causes of VTach could be your acid-base imbalance, could be electrolyte imbalance. The CHF commonly goes into VTach because their ventricles are already irritated and having issues. Could be some severe stress causing some, huge sympathetic nervous system response, but that would be pretty unlikely. I do see this with stimulants. I see VTachs with crack cocaine and cocaine use. Could be drug toxicity. So one of our drug classes here called TCAs, those are tricyclic antidepressants. Common tricyclic antidepressant would be amitriptyline or Eleval. These are commonly used off-label for not only depression, but also insomnia and migraines. So we have a lot of patients on Eleval right now. But TCAs cause something called prolonged QT interval. And our QT interval, which you started measuring back in that first week of cardiology, but our QT interval basically measures how long does it take from the depolarization of the ventricles to the repolarization of the ventricles. And a normal QT interval is about 9 to 11 small boxes, or 0.36 to 0.44 seconds. And some drugs like TCA causes a longer, so it's going to be over 11 boxes, causes an elongated QT interval. This could cause an RT phenomenon, could potentially throw you into VTach or VFib, so something we definitely want to watch out for. Usually, if they're following their medications regularly, we're not going to see this. It's when we have overdoses on our TCAs that we see this. Another medication I want to briefly talk about is digitalis. Digitalis or digoxin, anything with dig in it, it's a plant glycoside that we use to treat heart failure. And what digoxin does is it kind of increases how hard the heart contracts, so it increases that cardiac contractility, and it also helps control heart rate. So we use it a lot in patients who have atrial fibrillations, which are often related to heart failure, to kind of slow down that heart rate and make the left ventricle beat a little harder, because we probably have some heart failure in that ventricle. We can overdose on digoxin, so it has a very narrow therapeutic index, which means it has to be a very narrow level in your system for it to do what we want it to do. So when patients get digoxin toxicity, which means they've just kind of have too much digoxin built up in their system, it can cause bradyarrhythmias, which are going to irritate the ventricles, cause a lot of PVCs, and eventually a VTach, a torsades, or a VFib. And it can also decrease that cardiac output greatly. So we worry about with those digoxin toxicities. Early on, we'll see some things like T-wave inversions or ST segment depression, definitely some bradyarrhythmias. We could eventually have PVCs, which could trigger that RNT phenomenon. We go into VTach, VFib, or torsades. So with our ventricular tachycardia, and again, our most common cause, I know I just listed a lot of causes back there, but our most common cause is going to be myocardial infarction or ischemia. So we have some kind of coronary artery disease going on. We're going to identify it by its rate over 100 beats per minute. It's going to be regular. We don't have any P waves, but we have a wide QRS complex. And I don't really expect you to measure the QRS complex on these because they're hard to pick out, but you should be able to look at that and see that it is very wide. Next rhythm we'll talk about is polymorphic ventricular tachycardia. And this is also called torsades de pointes. So you can use either name for that. We commonly refer to it as torsades in class. But torsades has a very unique look to it. So we can see we definitely have some ventricular complexes because they're very wide. And then they're going to kind of get narrowed down. And then they're going to get wide again. So what torsades de pointes actually means in French, it means twisting around a point. So if I were to take a very thick ribbon and twist it, I would get kind of this wide, narrow look to it. And what's happening in torsades, so this is our heart. We have a pacemaker site in the ventricles and it's moving. Okay, so it's just moving back and forth from one site to another. This is very bad. It means our ventricles are very, very irritated. This will decompensate very, very quickly into VFib. So if the patient is not dead already, they are probably going to be dead soon. There are a couple different things that can cause torsades de pointes. One of our most common causes is going to be that prolonged QT interval. So we just talked about some medications that can cause that. Our tricyclic antidepressants and our digoxin, but there's also some other causes of prolonged QT. It could be, other than medication, it could just be another medication called azithromycin, so some antibiotics do that. But instead of medication, it could just be genetic. So there are some genetic diseases that cause a prolonged QT segment. There's also some electrolyte imbalances, so low potassium and low magnesium and low calcium can also cause prolonged QT. So magnesium, very, very important in depolarization of the heart, but it's also a smooth muscle relaxant. So we're actually going to treat our torsades with magnesium, just kind of giving a lot of magnesium. We'll get more into that next week. But looking at this torsades right here, and the torsades kind of starts over here, and you can see we probably had an RNT phenomenon that caused this one, but you can kind of see that it has this very distinct widening and then narrowing of the QRS complexes. So they're going to be very large and then kind of narrowed down. So you get that very distinct pattern of this widening and narrowing of your QRS complex. And you can definitely pick out a lot of QRS complexes, and especially when it gets really wide right here. So please don't mix this with the next rhythm. We're going to talk about VFib. So VFib is basically not conducive with life. And what's happening here is we've had some kind of cardiac, electrical conduction death. And kind of like AFib, where you get all kinds of firing in the atria, we're now just going to get a bunch of random fibrillation firing in the ventricles. Oops, sorry, I did not mean to zoom in there. So this is not conducive with life. Basically, our ventricles are firing off at multiple different locations, very chaotic, and it does not produce a pulse at all. So we're not going to get any kind of pulse with this rhythm. This is the most common rhythm disturbance in sudden cardiac arrest. So our patients that suddenly arrest on us kind of clench their chest and then go into a full arrest. Most common rhythm with that, associated with that. Could be caused by an RNT phenomenon, but our most common cause of VFib is going to be myocardial ischemia or infarction, just like VTAC. Could also be that digitalis toxicity that we talked about, hypoxia, acidosis, those electrolyte imbalances like low potassium, low magnesium, and low calcium. Electrical injury also causes VFib. So if you were to be electrocuted by a high voltage, whether it be a power line or lightning, any high voltage injury, could cause that RNT phenomenon, crisscrossing of those electrical pathways, and put you into VFib. And then also could be drug overdoses, but are ones that are either stimulants or cause that QT interval. So we're looking at cocaine and TCA. We don't see this with drug overdoses that are CNS depressants like opioids because it's not a stimulant. It's going to depress our heart, so that actually causes bradycardias. We have two types of VFib. You have very, very coarse ventricular fibrillation and very fine VFib. So one's just very wide and irregular, and one is just very, almost like an asystole. And this is important to note because I'd actually rather see this coarse VFib. Coarse VFib means they've died, sooner, whereas fine VFib, it gets more and more fine as time goes on. So we want to see that coarse VFib because it means the patient is just arrested. So not only do I not really have a lot of hypoxia, but there's a lot of electrical activity there left in the heart. And I can, try to change that. I can try to fix that and get a producing rhythm again. With fine VFib, more time has passed on. Our patient may not have a whole lot of electrical conduction left. They're definitely going to be more hypoxic. So our patient may not have as good of an outcome as if we have this coarse VFib. Our treatment of VFib, definitely look to that algorithm that's provided in your Canvas modules. But most important is going to be doing CPR. We definitely want to get blood flow to the brain and oxygenated blood at that. We do need to defibrillate this patient. We need to shock them as soon as we recognize this VFib. So as soon as you get your monitor on a patient, you recognize a VFib or pulseless VTAC, we want to defibrillate immediately to try to fix that rhythm and then go right back into CPR. We want to use epinephrine and amiodarone as our medication choices, and this also goes for pulseless VTAC. Always give your epinephrine first. We kind of have to prime the pump before we put in an antiarrhythmic to change the rhythm. So epinephrine will help cause some vasoconstriction and some cardiac contractility, and we're kind of getting the pump ready to accept some medications that's going to help fix this rhythm. So in your algorithm, you'll see that when it comes to medications, you'll give your epi, 1 in 10,000, 1 milligram every 3 to 5 minutes, but during your next cycle of CPR, you'll start giving those antiarrhythmics like amiodarone. And again, refer to your cardiac algorithm for that treatment plan. So defibrillation, just to talk about what that is, it's when we're putting these pads on the patient's chest. So you see these pads over here. It has a connector piece that'll plug right into our monitor. And these are just called quick combo pads or defib pads. But we're delivering a certain high amount of energy. And what American Heart recommends is that we start at 120 to 200 joules. Joules is just that measurement of energy we use for defibrillation, and that's with our biphasic monitors, and every monitor is pretty much biphasic now. So you need to know your manufacturer recommendations, but say these are my pads that I have on the patient's chest. All right, they're plugged into my monitor. I have one, on the front of their chest, and the one's going to be on the side. Just follow the pictures on where they want the pads put. What's happening with a biphasic monitor is I'm delivering energy from one pad to another both ways. So we're going to kind of cross the chest. A monophasic monitor is a little bit older style monitor, and we're just getting that delivery of shock from one pad to the other. So there's no kind of crisscross. So just a little bit older in technology, but now we pretty much use biphasic. So your manufacturer recommends 100 to 200 joules for biphasic monitors. Zoll monitors typically start at 120. 120 to 200. Your LifePak monitors typically start at 200. So know your manufacturer recommendations. With our LifePak, which is what I'm familiar with working with, we start at 200. Our next defibrillation is going to be 300. And then our next one's going to be 360. With the Zoll monitors, the X series I'm a little less familiar with, but the series before that we started at 120 joules, went to 200, and it kind of stopped there. I know the new Zoll X series go up to about 240, so they go a little bit higher. And that's just what the manufacturer recommends. If you're using a monophasic monitor, for some reason, if you had a monophasic monitor, you would just deliver 360 joules. So make sure you look at that flow chart, your algorithm, and watch John's video, and we can go over that treatment in lab. All right, next rhythm, one of the easiest rhythms to identify is going to be a systole. So this is just, we have a complete absence of any electrical impulse in the heart. VFib will eventually go down to a systole. It'll degrade into a systole once we've lost all of that electrical activity. Definitely confirm this. Make sure that your leads are correctly placed. Make sure that your leads are plugged into the monitor. If you're using your quick pads, your defib pads, to read the rhythm, make sure your monitor is correctly changed into paddles mode, which it'll typically do on its own once you plug in those defib pads. But we do still treat a systole. This is not a shockable rhythm, so we're not going to shock our patient. We're not going to defibrillate them because there's no electrical impulse there to kind of reset. Defibrillation is kind of like turning your computer off and turning it right back on, doing a hard reset on your computer when your computer's acting up. Kind of like restarting a car battery, just delivering a lot of energy to kind of get that started again. If we don't have any electrical energy there to work with, then we can't shock it. So this is just high quality CPR. We're going to give our epinephrine every 3 to 5 minutes. We're going to make sure we get good oxygenation. We're going to intubate our patient, all those things. And we're going to try to correct our 6 H's and T's to see if we can reverse this at all. But typically, patients who are in a systole have a very, very poor outcome. So a lot of times we'll call these in the field, depending on your protocol. Some say we work the patients for 20 minutes. Some say we do 5 cycles of ACLS. So depending on what your protocol is, you might even call this in the field. Most common causes of a systole are going to be your hypoxia and hypovolemia. Hypoxia is definitely the most common cause of this. So they're just not getting oxygen. They'll go into a bradyrhythm, eventually to a PEA, and then a systole. Another type of a systole that you may see, it's kind of rare. I've only seen this one time, and this is called a ventricular standstill. And so basically we have P waves, but we don't have any QRS complexes. So just another type of a systole, just call it a systole, treat it like a systole. All that's happening here is that the atria are contracting, so something's going on where the atria still has some kind of electrical impulse. But just our atria contracting alone does not produce a pulse. We need those ventricles to contract to create that stroke volume, to get blood out into the system to produce a pulse. So this is the same thing as a systole. And that leads us to our last rhythm, which is called PEA, or pulseless electrical activity. This is where we have some kind of activity on the monitor that looks like some kind of rhythm, but it's not producing a pulse. And it could literally be any rhythm besides VTAC or VFib, because we can, we treat those a little bit differently. Those we can reset. They could be in a normal sinus rhythm on the monitor, but not have a pulse. They could be in a junctional rhythm, not have a pulse. I've seen this with atrial rhythms sometimes, an A flutter and AFib, but not have a pulse. So there's still some kind of organization in the cardiac conduction system, but it's not enough that it's going to generate any type of pulse that would give us cardiac output. So we treat this exactly the same as a systole. Typically, these patients have a little bit better clinical outcome than a systole patient because there's still electrical activity there. We just got to figure out how to strengthen it. But again, still not going to be a very good outcome for the patient. Best cardiac outcomes for patients who are in full arrest are going to be your VTAC and VFib because we still have a lot of energy there. We just got to reset it. But your PEAs and a systole typically have a very poor outcome. We're going to treat this just like a systole. Good high quality CPR. This is not a shockable rhythm. Treat them with epinephrine every 3 to 5 minutes, and do our pulse checks, every 2 minutes. But this is another one we may call in the field. And make sure you're looking to Canvas for your PEA and a systole flow charts and algorithms.